All right. Hello, everyone.
Hi.
Good morning, good evening, and very welcome to the fourth already of our Enota Cost Action webinar series. And this month, the April edition will be about dose stratification versus therapeutic drug monitoring. And we have two excellent speakers today, Katarina Vučićević and Marlene Santos, who will be talking about these topics. And I will first introduce our first speaker, Katarina. So Professor Vučićević is a full professor at the Department of Pharmacogenetics and Clinical Pharmacy at the Faculty of Pharmacy at the University of Belgrade in Serbia. She is teaching pharmacokinetics, clinical pharmacy in the master's doctoral program, specialization programs where she's teaching on pharmacometrics. And in her career, she also did postdoctoral training at the University of California, San Francisco, where she worked on methodological aspects of PK and PD modeling. And today, her research is really focused on pharmacometrics modeling and simulation, with the goal to personalize dosing regimens of many drugs, including monoclonal antibodies, for patients to improve outcomes based always on PK/PD models in a user-friendly way. So Katarina is also an external expert for the evaluation of the bioequivalence studies at the Medicines and Medical Device Agency in Serbia. And she is also a member of the IETDMCT, or the International Association of Therapeutic Drug Monitoring and Clinical Toxicology, amongst many other positions in regulatory agencies. So, Katarina, the floor is yours. Feel free to share the screen. And for all the other for all the other attendees, please make sure to mute your mics. Questions can be shared in the Q&A, and we will address them at the end of this webinar. Thank you, Katarina, the floor is yours.
Okay, thank you very much for a kind introduction. And for the beginning, I would like to thank the leader of this Enota Cost Action, Denis, and in particular the leaders of WG2, Erwin and Elizabeth, for a kind invitation to present on this webinar series. So previous time, we have been introduced to the basics of TDM, and Erwin focused on the TDM concept and issues of therapeutic antibodies in immune-mediated inflammatory diseases. And moreover, he talked about the appropriate targets of mAbs, particularly infliximab, and about the utility of model-informed precision dosing as add-on to TDM, and how these targets may be reached. So today, I'm going to lean on his presentation, and I will synthesize current evidence regarding the reactive and proactive TDM for anti-TNF therapeutics in IBD, as this is where we have the most evidence. But before I start, let me share with you one of the most stunning natural resorts in Serbia. Uvac is a picturesque river with a unique meandering course through the beautiful landscape of the southwestern parts of the Serbia. And I hope that this picture is a good teaser for you to come and to visit Serbia. So, and one of the ways to enjoy the river, whatever river it is to take a ride with boat, maybe kayak, maybe do rafting. And just by taking a boat, you think that it's a perfect way to enjoy the nature. However, there are many challenges on the way. And these risks may depend on the season. Maybe they depend on the river intensity, whether it's mild, moderate, or severe, or wild river. Maybe it depends on the teammates you have on board, of their knowledge, skills, equipment that you have, and so on. So similarly, this is how I see the treatment course of IBD patients. The fact is that biological therapies have revolutionized the management of the IBD. However, approximately 1/3 of the patients with IBD show primary non-response to anti-TNF biological therapy. And this graph on the slide shows results from various studies for infliximab, adalimumab, but also for Crohn's disease and ulcerative colitis patients. So we see that the incidence of primary non-response is quite variable, and at the end, significant number of patients do not respond adequately. So primary non-response is typically defined as a failure to achieve therapeutic response, such as clinical remission or significant improvements in the symptoms after the initial induction phase of anti-TNF therapy. So primary non-response is a complex phenomenon which can be influenced by several factors, and consequently, various strategies may be applied to handle this event. On the other hand, from patients who are primary responders, again, significant number lose response during the maintenance treatment. So these patients are secondary non-responders. And we call this phenomenon secondary loss of response. Based on the results from various studies, as given here for Crohn's disease patients, annual rate of loss of response is up to 40%. And since secondary loss of response occurs after the induction period, the timing at which this occurs may be different among different studies due to different follow-up period, for example. And also for secondary loss of response, there are different mechanisms that are possible. So if the treatment failure happens, we have to react. And TDM is basically our reaction. Nowadays, TDM is recognized as the backbone of monoclonal antibodies therapy with the aim to improve the therapeutic outcomes. There are more data today which are available for the use of the TDM for anti-TNF agents than we have for non-anti-TNF drugs. And as we heard previous time, TDM is not only the measurement of monoclonal antibodies concentration and anti-drug antibodies levels, but it's also the interpretation of the results in the particular patient and performing adequate interventions in that patient. So TDM can explain why these negative therapeutic outcomes are occurring, and it can allow the identification of the patients who would benefit from those adjustments or from those who should switch to a different biological agent. So reactive TDM is defined as the evaluation of the drug concentration and anti-drug antibodies in the setting when primary non-response or secondary loss of response to a biological agent happens. So it can help us to explain and to better manage this treatment failure. It gives us the information about the cause of the treatment failure and offers rationale for subsequent therapeutic decisions in order to restore the response. It has been well documented, and today it is included in the guidelines. Based on the reactive TDM, both primary non-response and secondary loss of response can be attributed to either pharmacokinetic issues, which are characterized by the suboptimal drug concentration with or without the development of anti-drug antibodies, or maybe it can be attributed to the pharmacodynamic issues or mechanistic issues. Mechanistic failure may happen where optimal drug level is present, but there are undetectable anti-drug antibodies. Nowadays, we see from the results that non-immune mediated PK failure is attributed to 50% of a primary non-response and secondary loss of response. We see also that mechanistic failure rates are approximately 30%, and the remaining reasons of biologics failure are attributed to anti-drug antibodies mediated PK mechanism. On this slide, you can see one of the results to support reactive TDM, and in particular, this randomized control trial included patients with secondary infliximab failure who were randomized into two groups. In one group, we had infliximab dose intensification, as defined by the protocol, whereas another group was the group where interventions were based on reactive TDM. The results concerning the primary endpoint showed that the treatment costs were substantially reduced for approximately 30% in the group where reactive TDM was performed. However, the response rates concerning disease control at week 12 compared within these groups was similar. On this slide, you can see an example of reactive TDM algorithm, which is basically straightforward based on the knowledge we have. So when the patient have loss of response to infliximab treatment and have therapeutic infliximab concentration, then stopping the drug and changing outside of drug class may be considered, or a patient may undergo a surgery. If the patient have undetectable or low concentration of infliximab and undetectable or low antibodies to infliximab, then we can optimize by adding immunomodulator if there are low antidrug antibodies, or shorten interval and or increase the dose. And in the third situation, when the patient have undetectable or low concentration of the drug and high antidrug antibodies, then stopping the drug and switching within drug class using combination therapy with immunomodulator or monotherapy with proactive TDM, changing outside drug class, or having a surgery are options. Many prospective studies and post-hoc analysis of randomized controlled trials showed that there is a relationship between exposure at a particular time point and different responses at the specific weeks of the treatment. They also show that a higher concentration of biological drugs are associated with increased rates of favorable therapeutic outcomes, including clinical remission, biological remission, endoscopic remission, and so on. So having this on mind, we may act proactively, and perhaps we can prevent negative events which may happen. So proactive TDM is defined as the evaluation of drug concentration and antidrug antibodies with the goal of optimizing biologics to achieve specific target and better therapeutic outcomes. Intentions of proactive TDM are going into several directions. One of them is to predict short and long-term clinical outcomes and adjust the treatment basically as soon as possible during the induction phase, then maintaining therapeutic target exposure and adequately maintaining the treatment and prevent relapses, reducing the risk of complications, but also we can think about the escalation of the dose of the monoclonal antibodies when the patients are in the remission, as this intervention would save costs due to the overexposure. So let's see what are the current evidence regarding proactive TDM. The first randomized controlled trial to evaluate TDM-based dosing to maintain remission in IBD patients treated with infliximab is this TAXIT trial. Patients were randomized into two groups, one where infliximab dosing was based on their clinical features and C-reactive protein, and another group where infliximab dose was based on TDM, targeting a level between 3 and 7 milligrams per liter. TDM-based dose adjustments did not show statistically significant difference in clinical remission at week 52 over clinically based dose adjustments for the total population, as well as for the subpopulation of chronic disease and ulcerative colitis patients. As every trial, also this one can be critically appraised, and maybe by looking more deep into the design, we may see what are possible reasons for having this kind of results. Additional results from the same trial regarding duration of remission and relapse are based on the time to relapse analysis using Kaplan-Meier analysis, and they indicate that clinically based dosing was associated with a higher need for rescue therapy, for dose escalation, for adding steroids into treatment, and so on. And as you can see, these curves begin to separate starting from week 26 by week 52, as this was the follow-up period for the study. Furthermore, TAILOR-X trial is another randomized controlled trial which failed to support proactive TDM as well. The primary endpoint in this trial was sustained corticosteroid-free clinical remission from week 22 through 54, with no ulcers at week 54, no fistula or surgery. So increasing the dose of infliximab based on the symptoms biomarkers together with therapeutic drug monitoring did not lead to corticosteroid-free clinical remission in a larger proportion of patients than increasing the dose based on the symptoms alone. Here is another randomized control trial with approximately 400 patients with one of 6 immune-mediated inflammatory diseases receiving their randomization intervention, either proactive TDM, which was based on predefined algorithm, or standard infliximab treatment with treatment adjustments based only on the clinical assessment. So the primary outcome of this study was clinical remission at week 30, and this is the Nordrum A trial, which showed that there was a comparison, or the clinical remission was comparable between the two groups. So proactive TDM compared with the standard therapy did not significantly improve remission rates or any secondary efficacy outcome. However, Nordrum B randomized controlled trial aimed in assessing proactive TDM versus standard of care in keeping disease under the control in patients with one of 6 immune-mediated inflammatory diseases who were on maintenance therapy now with infliximab. The results showed that the patients receiving proactive TDM now had a lower probability of disease worsening at week 52 compared with the standard therapy group. And these curves, show very nice separation on the plot given on this slide. Previous time, we were introduced to the concept of mAbs-based therapeutic drug monitoring. So this randomized controlled trial, precision trial, confirmed that using PK-driven dashboards as an add-on to TDM, to traditional TDM for infliximab dosing during the maintenance treatment for IBD resulted in higher proportion of patients with sustained clinical remission after the period of 1 year compared to the standard dosing. Moreover, mAbs group also resulted in lower fecal calprotectin levels and clinical remission as a composite outcome of the trial. While all of these findings that I have shown you originate from the randomized controlled trials, it is also very important to acknowledge that there is a great number of publications and results which come from retrospective and prospective studies conducted in a real-life clinical settings. And this is just one of them, where long-term outcome of IBD patients were compared among groups undergoing proactive versus reactive infliximab TDM. A total cohort of patients was approximately 250, a bit more of that, which were followed up to 6 years. The median time for a follow-up was approximately 2.5 years. Treatment failure, as given on the figures, was defined either as a discontinuation of the infliximab due to the loss of response, or, for example, need for surgery or some other situation. In the entire cohort, 17 proactive group patients had the treatment failure during the follow-up period, whereas in the reactive TDM group, 88 patients had a treatment failure. And these results indicate that there is an augmented value of proactive TDM. It is obvious that we have conflicting results concerning proactive TDM. Therefore, meta-analysis is used in research to synthesize and to integrate the findings which are coming from multiple studies. Of course, meta-analysis itself has limitations and they have some assumptions that has to be considered, such as quality of included studies, potential bias, appropriateness of combining different study designs together, and so on. This meta-analysis is published in 2023 and focused on the TDM efficacy of anti-TNF drugs in inflammatory bowel diseases. And here are some of the results for proactive TDM. Proactive TDM of anti-TNF therapy compared to the standard of care was associated with significantly reduced treatment failure, as well as improved endoscopic and clinical remission, but without the statistical significance. This figure on the slide shows the meta-analysis results for the treatment failure. And as you can see, this red diamond favors proactive TDM, and the confidence interval for risk ratio does not include 1. On this slide, you can see the results of the meta-analysis where proactive TDM was compared to reactive TDM. And we see that the proactive TDM is associated with a significant reduction in the need for surgery as well as treatment failure. And similarly, like on the previous slide, confidence interval does not include 1 for the risk ratio. So overall, if we go to this meta-analysis and also if we see additional study results, we see that proactive TDM showed a number of favorable outcomes compared to standard of care and also compared to reactive TDM, suggesting that it could be one of the preferred TDM strategies in IBD patients. However, if we look at the guidelines and recommendations from various groups, associations, organizations, despite the existing results of the studies, they do not all agree. And at the moment, we do not have unconditional, let's say, recommendation in guidelines regarding the position of routine proactive TDM of biologics. So definitely there is a need for more large, high quality, randomized control trials in order to support proactive TDM. This means that there are opportunities for research, and I'm sure that many members or all members of Enota Cost Action are determined to contribute to the advancement in this field and to fill in the gaps in knowledge which exist at the moment. Many of these gaps have been mentioned by colleagues on previous webinars, but also when we talk about proactive TDM, there is a need for more evidences. And also we have to see and we have to go beyond anti-TNF drugs for IBD patients. So we need to optimize, since one obviously protocol does not fit all clinical situations. It's obvious that one target concentration does not fit all treatment outcomes nor treatment phases, and one dose, of course, does not fit all patients. Somehow, I hope that by filling the gaps that exist, we will support our patients and go on a ride and enjoy the ride with our patients suffering from immune-mediated inflammatory disease. So for the end, let me acknowledge just once again ENOTA Cost Action, as well as the Science Fund of Serbia for supporting the project that we just started. And I hope that we will contribute to the field of monoclonal antibodies monitoring in IBD patients. Thank you very much.
Thank you so much, Katarina, for this very nice presentation, very insightful, and also highlighting a few of the important knowledge gaps. Questions we will take at the end of the webinar. So now we can proceed to our next speaker, who is Professor Marlene Santos. Marlene holds position as an associate professor at the School of Health, Polytechnic University of Porto in Portugal. Her research is mainly focused on pharmacogenomics, molecular mechanisms, and personalized medicine in a variety of contexts, including psychiatry, neurological, and inflammatory disorders. That's also where teaching activities are focused on, again, pharmacogenomics, neurophysical pharmacology. She is involved in several research projects related to personalized medicine. And also very important to mention is that Marlene is actually the lead of Working Group 1 on patient stratification in the ENOTA Cost Action. So I think Katarina already highlighted a knowledge gap, the pharmacogenomics, the patient stratification, which patients might need TDM. And maybe, Marlene, you have more to say about this. The floor is yours.
Oh, thank you so much, Erwin, for that lovely presentation. And first and foremost, I want to extend this thank you to Elizabeth as well for promoting all of these webinar sessions together with you, Erwin. I would like to thank also Denise Mullman, the chair of another session, for promoting this another cost action and to gather us all together. So if I may start the presentation. So I think you can see my presentation now. Erwin, can you confirm it? Yes, okay, thank you. Yeah. So today I will be speaking about dose stratification in chronic inflammatory disease management through pharmacogenomics as a way to provide this tailored treatment in chronic inflammatory disease. So the index of today's presentation will include the understanding of chronic inflammatory disease treatment, the importance of pharmacogenomics and its applications, the need of dose stratification and the tailoring of the treatment in patients with chronic inflammatory diseases, considerations and implementations challenges that we'll be facing with pharmacogenomics, and future directions and the opportunities. So first, I'd like to, first to think about the importance of monoclonal antibodies in chronic inflammatory diseases. So we have several different types of monoclonal antibodies, and the first ones that have been used are targets towards the pathway of tumor necrosis factor alpha, or TNF-alpha. These are usually when patients don't respond to other lines of treatment, including anti-inflammatory drugs and modifying disease, synthetic modifying disease drugs. Usually they jump to inhibitors of TNF-alpha. These drugs that include infliximab, adalimumab, golimumab, certolizumab, and etanercept control cell proliferation and differentiation, and thus try to limit the pro-inflammatory response. So usually these drugs are prescribed, as I said before, when patients do not respond to the previous treatment lines or approaches, and where they present moderate to severe forms of immunoinflammatory diseases. These treatments are actually efficacious, and they try to ameliorate disease control, reduce hospitalizations, and improve patients' quality of life. But they also present some limitations, and there are some patients that do not respond to treatment, or some of them present relapse. And there are several factors that could explain these heterogeneous phenotypes of response. Well, physiological factors are among the first factors that could influence this response, including age, sex, width, or other concomitant diseases, as well as environmental factors, including the concomitant drugs treatment that could influence TNF-alpha inhibitors, the diet, tobacco use, alcohol use, or even other chemicals. Among other factors, there are including genetic factors. And among these genetic factors, we can speak about variations in genes related to drug metabolizing enzymes or drug transports. But we must also think about the targets of the drugs that are also can be also influenced by genetic factors. So in taking this in consideration, so why should we focus on pharmacogenomics in the context of monoclonal antibodies for dual stratification? Well, the clinical use of mAbs has shed light on their pharmacokinetics characteristics, as has been already shown in the previous presentation. So characteristics as the small volume of distribution, the clearance depending on several processes, and the fact that these neglectable renal excretion, as well as the presence also of anti-drugs antibodies, they present these pharmacokinetics limitations. I'm sorry, and also these alterations in the pharmacokinetics may be due to the fact that are inter-individual variabilities. And as I mentioned the factors before, there are several reasons for this. One of these reasons might be genetic factors, and they may depend, this pharmacokinetics response, they may depend on genetic polymorphisms or genetic variations. So pharmacogenomics, well, it's a branch of pharmacology, and it explains the influence of genetic variations on drug response or drug adverse reactions. Among these genetic variations, well, there are the single nucleotide polymorphisms as one of the variations that is most usually studied. And pharmacogenomics has this potential of try to develop this regional means of optimizing drug treatment, taking in considerations patients' genotype. This will assure the maximum therapeutic effect with the minimum of adverse reactions. This approach is also a way of personalizing treatment or personalizing medicine that is a really now a target of therapies that would together with other biomarkers, could optimize individuals' treatment. Regarding the pharmacogenomics targets, as I said, pharmacokinetics genes are usually the top target genes when it comes to drugs. Polymorphins in CYPs, in cytochrome P14, and genes that codify for the several isoforms of P415 cytochrome have been implicated in several treatment responses. But also, we should not forget about the pharmacodynamic targets. And when it comes to inhibitors of TNF-alpha, one of the first genes that we might think of is the TNF-alpha receptor. But there are several studies I will present after where other targets have been addressed, and in order to try to direct the treatment efficacy and also to prevent other potential adverse reactions or other risk factors. For instance, the risk of immunogenicity. That is one of the problems that may arise for the use of mAbs. The goal of pharmacogenomics is try to divide our patients in phenotypes according to its genotype. So usually the one-fits-all model, as Katarina already mentioned, where we treat all the patients with the disease with the same drug at the same dose. It's a not up-to-date envisioning model. So the pharmacogenomics model tries to characterize these patients according to its genotype. Before we prescribe a treatment for a group of patients that share these phenotypes, we are already aware if they will benefit for this treatment or not, or if we should choose an alternative drug. There are several evidences from the literature about the use of pharmacogenomics in treatment selection. And these evidences, we can think about dividing these evidences in the evidences from the literature, the curated and graded evidences, and also the guidelines based on pharmacogenomics studies. So the first evidence that we have for pharmacogenomic studies are usually come from studies, and first the most significant evidence comes from meta-analysis. But this meta-analysis is also based on clinical trials that have been correlated with the correlated genetic variations with treatment outcomes. And we have several papers published on the pharmacogenomics of TNF-alpha inhibitors in immunoinflammatory diseases. Also, there are some agencies, for instance, the Food and Drug Administration, FDA, that pick these informations and for some drugs already demand for these variations to be warned in drug labels, so that the prescribers have this information before they can prescribe the drugs. In Europe, this drug label information is not as demanded by EMA to be included in the drug label, but we are coming also to this point as well. What interests is So how can we go from the pharmacogenetics evidence for this medication dosing and selection so that the clinician can, in fact, prescribe the right drug for the right treatment? Well, there is one structure that regarding pharmacogenetics has been doing a great job, which is Pharm-JKB, that address the evidence from the literature, from clinical trials, from systematic reviews, from meta-analysis, and it grades the evidence in preliminary, low, moderate, or high evidence. And this will help the clinicians and the investigators to have more solid evidence for the influence of a specific variation in a specific outcomes. Also, based on this information, there are several agencies that promote pharmacogenomics-based guidelines. The most important is the SPEAK agency, which is the Clinical Pharmacogenetics Implementation Consortium, that produces guidelines based on pharmacogenomics, and it tailors, for instance, the dose of the drugs, taking in consideration the genetic profile of a patient. So this will be, well, the perfect instrument for the clinician to prescribe the right drug with the right dose for the right patient. I will be speaking about these three levels regarding the evidence of monoclonal antibodies in inflammatory conditions. I'll be speaking about the inflammatory bowel disease, and there are several candidate genes that have been used in pharmacogenetic studies. Regarding the TNF-alpha inhibitors, there are several drug-related genes that have been proposed to correlate, for instance, with immunogenicity. For instance, the HLA-DQA1 gene and the presence of STAR5 polymorphisms. Regarding the response to infliximab, it has been correlated with the ZNF133 gene. And regarding the response to TNF-alpha, we have several genes that have been correlated. Among these, we have the TNF-alpha gene, the TNFR1, TNF-AAP3, and among others. Regarding the rheumatoid arthritis, this is the result of meta-analysis of anti-TNF-alpha treatment response in rheumatoid arthritis. And here, the results of this meta-analysis should suggest that the genetic variants of CTCN5 and OBL, and PL2D, as well as EIA4 and TEC from GWAS studies have been correlated with the response of TNF-alpha inhibitors in rheumatoid arthritis, as well as TRF1, NFKB1, and FCCR2A. And some of these I will present here. For instance, this FCGR2A, which is codifies for a gene, a member of family of immunoglobulin Fc receptor found on the surface of many immune-inflammatory cells, and also autoimmune disease with elevated antibodies drive tissue damage. And these FCI receptors bind AGG subreceptors, modulating the clearance of circulating in immune complexes. And regarding this gene, we can see that this gene is associated with an increase. You can see the diamond here, increase in risk of non-response. For instance, another gene, which is the TRAF1, there is one polymorphism, the RS37 847GG homozygotes have been associated with higher JP antibodies when compared with AA homozygous. And also AA homozygous has been associated with a higher antichromatin compared with the GG homozygous, and this might explain the differences in treatment response as well. So these are some of evidence of the literature. But as I said, PharmJKB is this database that includes and tries to take together all of this evidence from the literature to produce guideline annotations, drug label annotations, and also curative pathways. And we can search here for the drug or the molecules that you want to select. And we can analyze the evidences regarding the drug label. Sorry, regarding the clinical annotations and etanercept, there are most of the evidence are from level 3, but actually regarding etanercept, we have a level 2 evidence. Well, level 2 is a moderate evidence for the use of these genetic variations in order to optimize treatment. And in fact, this level 2 evidence arises from TNF-alpha gene, the RS1800629, where patients with GG genotype may have an increased response to etanercept compared with AA or AG genotype, while the patients harboring AA genotype may have a decreased response to etanercept. And this evidences have been proved in several diseases, several inflammatory diseases, including arthritis, psoriasis, rheumatoid arthritis, Crohn's disease, inflammatory psoriasis, inflammation, and spondylitis ankylosis as well. Regarding other TNF-alpha inhibitors, infliximab, it only has level 3 evidences and some level 4. There are about 20 evidences, 20 clinical annotations. Regarding certolizumab, well, we have about only 4 clinical annotations arising from clinical studies. And adalimumab, we have nearly 17 as well. So I want just to point out that there is no prescribing info taking together all of these evidences because the evidences are too low. If we have, for instance, a level 1B or 1A evidence, we would probably have this drug prescribing info based on these genetic variations. But right now, unfortunately, we don't have enough studies. These level 3 studies are usually studies that, well, are done with a small number of patients, or the design of the study is not the best one, so they can annotate this as a solid evidence. Also, we may think that pharmacogenomics might be also integrated with TDM. So as we already spoke today about the benefits of proactive and reactive TDM, we also may think that introducing pharmacogenomics would be a way of allow patient segmentation and personalized pharmacological therapies in the early induction phase. So then after the treatment would be again followed by a sustained proactive TDM protocol. So these both approaches could, for instance, give the best treatment for our patients and give the right drug for the right dose for the right patient in the right time. This is, pharmacogenomics displays really an important role for treatment personalization, but we also must think about the limitation of its application. And there are several limitations. First, the ones regarding the testing, the cost of the test and availability of the test. There are some laboratories here in Portugal already performing this analysis, but usually they are used for other diseases, for instance, for cancer treatment personalization. Also, there are some other barriers, including the lack of standardization terminology, the few some limitations on clinical informatics systems and the integration of the genomic informations in patients' personal files. Also, some limitations regarding the clinical selection of the patients. For instance, there are few drugs or dose selection algorithms. I presented here some of these evidences, for instance, for the pharmacogenomics in TNF-alpha inhibitors, but actually the SPIC, given the low evidence presented by the studies, does not have yet a guideline for TNF-alpha inhibitors in immunoinflammatory diseases. So, regarding this topic, there is the need of this guideline, but first we must have this really standardization of the nomenclature, and also we must have some evidences that could support these recommendations. Also, there are some limitations regarding training and knowledge of the future health professionals in terms of dealing with pharmacogenomics and of this knowledge of these databases and how to interpret data. And also, we must not forget the limitations regarding the ethics point of view. So we are aware of the importance of genomic data's protection. Given all of this information, we might also think that there is some room for pharmacogenetics to be included in the treatment selection for our patients. And as I presented the slide before, might be integrated with TDM, and in order to give the best treatment for our patients. So thank you again for the assistance, and also thank you for Enota and Irene and Elizabeth for promoting these webinars. Thank you.
Thank you so much, Marlene, for this very nice overview. I really like the message that it's not just TDM or pharmacogenomics, but that we should all collaborate. Before we go to the questions, let me also thank a few people. So first of all, my co-host, Elizabeth, with who I lead working group 2 on individualized treatment. And then today, Elizabeth was taking care of everything behind the scenes. So thank you for that. And also, Denis Willeman is here, our cost action chair, who I think is doing a wonderful job in coordinating Enota. And then finally, I also want to thank Mehmet, who could not be here today, but Mehmet is responsible for taking care of the website and advertising our webinars. If I forget people, delete, please help me. Otherwise, we can go to a few questions from the audience.
Yeah, Marlene, thank you very much. It is correct that we haven't paid so much attention during the past 10 years on the pharmacogenomics, and it is something that maybe we have to pay more attention, certainly, because when we make the model, and there is a part of the variability that we can explain, but there's a lot that we cannot explain, and maybe it could be in the genes. But yeah, we have to, so there must be some approach to see how much we can understand when a patient is not responding, and it is certainly something to do with genes. And there are also more trivial characteristic, just only as weight, just only something like this is also, but it does not. There must be something else. So, and I thank you to open our eyes in the direction of the genetic factors. I just would like to make a comment on the overview of Katarina. It was very nice, and I think that you show that there's a lot of society from the US, from Australia, and many more. And this reminds me the picture of Erwin during our last meeting in Porto, by the way. So everyone agrees on the principle that there's something to do with TDM, but there are some differences how to deliver this technology, actually. And sorry. And this is why ENOTA is to assist all the people who are participating to ENOTA and to approach the policymakers. Because when you see all the evidence, there are some evidence, but they are not that high as we might expect it. But there must be something that we have to do is to approach the policymakers. And this is something that we're going to do in ENOTA. So I have contacted Georges Carregas, who is responsible for the dissemination working group, and to approach the Joint Research Council. I hope this will be done in this grant period, the second grant period. Yeah, and particularly for IBD, because there are more and more evidence coming up. And what we have shown is, I think it's something that people have to take into consideration. We cannot treat the patient as we did in the 2010. I think we have to.
Yeah, I mean, thank you, Dennis, very much for commenting, and I agree completely what you just said. We are all hoping for very good big randomized controlled trials, but actually in the practice we have sometimes scenarios which do not perfectly fit the trials. And clinicians, they rely on what they see in everyday practice. And sometimes for them, this is a good evidence, to perform some interventions, activities, and so on. So I believe that also this ENOTA group will contribute to the body of evidence that we have, and that we will communicate the results that already exist, and probably some of them which are coming in the near future. Thank you very much.
Yeah, I think that's a very nice and hopeful closing of our session. If there are no further questions, then we're happy to discuss during further meetings. But I think then we can wrap it up for today. Thank you all for attending, and hopefully see you again next month for the next webinar. Have a nice rest of your day.
Thank you.
Thank you.
And thank you again
Bye-bye.
to the speakers.
Bye-bye. Thank you.
Bye.
Bye.